My name is Benjamin Summers. I work at the Harvard School of Public Health and at Brigham and Women's Hospital in Boston. So the article that I wrote with two colleagues in our department here that was published in New England Journal of Medicine was exploring the hypothesis that when you expand Medicaid to low-income adults, that it would improve access to care and improve health and survival for low-income adults. The Affordable Care Act expands coverage to millions of Americans in part through a large expansion in Medicaid eligibility. The law takes the existing categories of eligibility, which typically include parents, children, pregnant women, and those with disabilities, and now adds to that essentially any low-income adult with a family income below 138% of the federal poverty level. So this is a huge change in who's eligible for Medicaid. Under this expansion, a key question then is, well, what happens to those individuals when you expand coverage to them? And our paper sought to explore that issue by looking at several states that had done a similar expansion on their own earlier in the decade. So we picked the 3 states that since 2000 had made significant expansions in Medicaid to this group of low-income adults without children, without disabilities. And the states were New York, Arizona, and Maine. During the past decade, while other states have made other health policy changes, none had done the expansion that's so similar to what the Affordable Care Act does. Massachusetts, for instance, had a major change in its healthcare system in 2006, but this included private insurance and other types of coverage, not just a Medicaid expansion. So we really wanted to focus on those states that were using Medicaid as a way to cover low-income adults. Our data come from a variety of different national publicly available sources. Our main outcome is overall mortality, and we get that from the Centers for Disease Control and Prevention, who have a data set that captures every death in the United States each year. It's called the compressed mortality file. We also then looked at household surveys that had information on insurance status, on access to care, on cost-related barriers to care, and self-reported health. And those surveys came from CDC and from the Census Bureau. So in addition to looking overall at the adult population, we also wanted to look at several specific groups that we hypothesized would be more likely to benefit from getting Medicaid. So we looked at, we compared whites and non-whites, we looked at older and younger adults, and then we also looked at those who are living in poorer or wealthier areas. And we did that based on the poverty rate in the county that a person lived in. So we found that overall, states that expanded Medicaid to adults between 19 and 64 years old had a decline in their death rate of about 20 deaths per 100,000 people. Relative to baseline, this is about a 6% decline in deaths each year. And so this is a fairly significant population-wide effect that was attributable to the Medicaid expansions in those states. So what we looked at, in addition to the overall outcome mortality, were several outcomes along the way. If you're going to hypothesize that insurance eligibility makes a difference in someone's mortality, it has to be true that they sign up for coverage and that they use that coverage to access services. So with the different data sources we had, we were able to see that, yes, significant numbers did sign up. The number of uninsured adults dropped dramatically in those states compared to the states that didn't expand Medicaid. And then when we look at whether or not a person said they couldn't get care because of costs, states expanding Medicaid had far fewer financial barriers to care. So people were able to get the care they needed when they needed it instead of waiting because they couldn't afford it. Well, it's a great question. Our data set doesn't give us the level of detail that you would really need to be able to answer in particular what different treatments they got that they weren't getting. We know from previous research that in general, when people who are uninsured gain insurance, they experience better chronic disease management for conditions such as diabetes and high blood pressure. They have better medication adherence. They're less likely to wait till they have severe problems before pursuing care. And they're also more likely to have a source of regular care through primary care. So all of those factors are probably contributing to produce the health effects that we're seeing. But our data set doesn't let us look at those individual treatment decisions. So this paper was started well before the Supreme Court had even agreed to hear arguments about the Affordable Care Act. The fact that the paper came out shortly after the Supreme Court ruling was somewhat of happenstance. But the Supreme Court's ruling did have a significant impact by making the Medicaid expansion essentially a state option. It's hard to tell exactly how this is going to play out. A lot of the states currently are taking a wait-and-see approach until after the November election, based on who's in the White House, based on the Senate. They'll figure out whether or not they're going to go ahead with the expansion. In the long run, assuming that the law stays on the books, I imagine most states ultimately will take part in the expansion. Whatever the political arguments are right now, this is a lot of money from the federal government to subsidize care that a lot of states are already providing for in other ways through uncompensated care, or that providers are on the hook for. So provider communities are going to be pushing pretty strong, along with patient advocates, to say there's a federal share of spending in Medicaid would be 90% in the long run. We need that money to take care of our low-income populations. So a handful of states might hold out, but I think most probably will ultimately decide that this is good for the health of their state, health of their population, and it is also financially a good deal for them. So the way that the law is set up is that currently Medicaid is paid for by a combination of state and federal sources, and the federal government, depending on the state, pays about 60% on average. Under the Affordable Care Act, these newly eligible adults will actually get paid for 100% by the federal government for the first 3 years, and then in the long run it settles out at 90%. So while the state share does go up over time, it's still far below the current state spending on previously eligible Medicaid enrollees.